Welcome to the Wound Masterclass Podcast. Thank you for joining us for this 30 minutes of delving into the most important topics in wound care. My name is Negin Shamsian. I'm the editor of Wound Masterclass, and I'm one of your co-hosts for this podcast. I'm joined by Alec Wright, who is the other co-host.
Thanks very much. Very happy and excited to be doing this. I'm also delighted to welcome our first ever guest, Harm Jaap Smit. So how did the conversation go?
It was great, actually. But Alec, why don't you tell us first which city in the Netherlands Harm Jaap Smit is from? It's a difficult one to pronounce. This is why I'm asking Alec to take on the pronunciation of Harm's.
Linguistic expert.
Absolutely. So how did we think it was pronounced? We can ask Harm in a minute, but Amersfoort. That was our best guess. Yeah, so it was exciting, actually. Talking to Harm. Harm is one of these experts. He's a wound biologist from the Netherlands, and he just manages to give a very uncensored, raw opinion on wound care, which is, really unusual, because usually most of our opinions can come through a filter of what's expected to be said. But I find the beauty of a conversation with Harm, who I've known for many years, is that he's just very undiluted and honest in his opinions. So yeah, it's really interesting to get that focus from him on what he believes are the myths and misconceptions in wound care.
Yeah, that sounds fantastic. I think that kind of straight talking is definitely something we need more of in this sphere. So it's my pleasure to introduce that conversation with Harm Jaap Smit.
Harm, thank you very much for joining us for this Wound Masterclass Interactive podcast.
Mm-hmm.
And really excited for you to join us because, you've been a wound expert for many years, and I always enjoy reading all your LinkedIn posts. They're always eye-openers. And I guess today we got together to discuss myths and misconceptions in wound care, of which there are many. So let's see. I'm trying to think about your recent posts. I liked the one you did recently that talked about how different cells react differently to trauma, and therefore we can't predict wound healing is going to be the same in each scenario.
No, of course not. Yes, no, you're right. No, and there's another thing which happened a few days ago. Someone published an article in a Dutch nursing magazine, which has to do exactly with exactly the same problem we have all over the place. And that is, she published a paper on how she cured an ulcer by means of proper tender loving care, as we call it.
So tender loving care, that
tender loving care.
Healing.
Yeah, so cleaning the wound. She had a deep knowledge of what dressings or what to put on a wound, and then to her surprise, the wound closed. But looking at it, I realized that wound didn't close due to her tender loving care, but due to the fact that she stumbled upon a problem which she totally misconceived, but then nevertheless did the right thing, and that is apply a local corticosteroid. So the idea was that the leg ulcer was caused by arterial problems. But then if you look at the leg ulcer, you see a pattern of many wounds all over the shin. So that is not exactly what you expect by a arterial ulcer. Mm-hmm. And then she didn't look into it. She said, well, let's see if we can clean it up and close it with tender loving care. And then my question is always, well, if you have a closed vessel, how are you going to open up that vessel with your dressing? That's not going to happen.
Yeah, even tender loving care is not going to vasodilate that, is it?
No, it isn't. So then we had the problem that how does this arise? How can it be that someone thinks it's an arterial ulcer or an ulcer with an arterial problem, gets handed over a patient and doesn't get handed over the proper information? So that is, I think, one of the main problems in wound care, is that we have lack of expertise, or people who should be doing their job are not doing it. Because how on earth are you going to hand over a patient to a nurse without giving a proper diagnosis or telling them what to expect. And it just didn't do it. And then if you only have a hammer, every problem looks like a nail. So the dear nurse, who has, I'm quite sure she has years of experience. So she knows exactly what materials to use on that wound and how to treat the patient. But somehow she forgot to think about why is that wound here? What's going on? And that's the weird part of these things. And we see it all over, because if I'm looking at my other hobby today is looking at data, and then you see outliers. You see patients who are not behaving like the flock. And then the question is why? And nobody asks the question why, which is really, really weird. So this patient, it turns out I'm still looking for second opinions for that, because it is an article, there's a picture there, but from 2 words in a picture, you can't diagnose a patient. And I'm a biologist, so by no means I'm able to set a diagnosis. I can only ask questions and think like, well, that looks like a dermatological problem or a vascular problem, and we have to exclude both of them. So why isn't this patient seen by a proper dermatologist or a proper vascular surgeon? Because the other thing, it was a diabetic patient, which even gives it more trouble. The other problem is that they have been talking to this lady about, we will have to amputate your leg because you have a problem, because she has had wounds for months. Well, if that wound has closed by means of tender loving care and corticosteroids, it means it wasn't a vascular ulcer at all, which means that the amputation danger is also not as present as they thought. But then if you start talking to a patient about, we're going to take your leg off, they're going to shy away from any kind of intervention. So the other underlying storyline is that this patient also refused to have further diagnosis because she was quite sure that would cost her leg. So here you have, it's a bit hard to because it goes from all over the place, these type of stories. But here you have a patient who has had an improper diagnosis, someone who thought that there was a vascular problem causing these wounds, and since the wounds didn't close, they thought, well, let's amputate the leg, tell the lady scares, says, I don't want to do that, send me home to a nursing home where we have a proper nurse, and the proper nurse starts doing her best to her knowledge, which is absolutely not what should have happened here.
And there's lots of these little rabbit holes in wound care, isn't there? Where if you fall down one of these rabbit holes, you could be undergoing, certain treatments on the wound, which may not be making any progress on the wound. So
no.
And it's quite easy to get sort of diverted, isn't there? And then suddenly a wound can become a hard to heal wound. It becomes a chronic wound. And it's almost a stigma, isn't it, for the wound? Because then people think, oh, well, they've tried everything here. What's the next step?
Yes, but now you're hitting on the next problem, that wounds over time become hard to heal. I think we're missing a big issue here. If I look at data from a GP office, there we see, let's say, 1,000 patients. And of those 1,000 patients, 900 heal within 4 to 6 weeks. So, and what you have left over is then 100 patients, of which there are about, let's say, 20, 1/5 is hard to heal. So if you talk about hard to heal wounds and you say the longer it takes to close them, it means you're also changing your filter, because you started with 20 patients on 1,000 patients, which is 2%. They're non-healing wounds. And then suddenly, after 6 weeks, you're stuck with 20%, 20% non-healing wounds. So then it is easy to start thinking that, oh yes, the longer we wait in healing these wounds, the harder they are to heal. Well, that could be not the case. It could just be the case that you're selecting for the harder to heal wounds. So what you're left off is with hard to heal wounds. So the whole idea that if a wound deteriorates over time and becomes harder to heal has at least 2 aspects. The first aspect is that, well, you get rid of the ones who do not heal, who heal easily. So they're out of the equation. And then the second thing is, and this is also very hard to find, is, all right, if they are harder to heal, what mechanism makes them harder to heal? And then you run into the hobbies of countless people, of numerous people, who then start talking about matrix metalloproteinases and all kinds of other things. But what you're looking at is a system where these things are what you can observe on the outer surface of the system, but that's not what's happening in the system. So if you are telling me that, yes, if you wait longer, the wounds become harder to heal, I agree, but not to the extent that it's currently believed. I would say 90% of those patients are just normal patients with a hard to heal wound. This doesn't mean it has deteriorated during the time beforehand.
Do you think, Harm, then these hard to heal wounds that are labeled as such are actually wounds that have not been managed the way that they should have been initially? And that's why they're in that scenario. Is that sort of...
Not even that. I think that if you have 1,000 wounds and you have 20 of them which are hard to heal, that they will surface over time, because over time all the other wounds close. So you're left with the harder to heal wounds. So they're not per se mistreated. The other thing, of course, is what they can be mistreated if you're not recognizing them. So that's the other game, is how do we recognize on day one? How do we fish out those 20 wounds out of the 1,000 wounds, which are going to cause a problem?
Interesting. And what do you think is the best way to do that then, Harm?
Well, if I would know that, we wouldn't be talking here like that. And the other thing is, if it's easy to find, we already have found it.
True. So it could be multifactorial, patient factors, local wound factors, perhaps.
Yeah. The other day, I because I always need mental gymnastics to think about wounds. And the other thing is, if you start comparing having a wound to having a fever, and then think about that. So how do you know? Everybody has a fever every now and then. You go to the GP and they say, well, depending on where you are, they either say, well, have a hot cup of tea and have a blanket and sit it out. Nothing will happen. Or they will provide you with all kinds of medicines, which where we can have a nice discussion about. So that's also the game. How do you know that someone with a fever is having a problematic fever? So how do you recognize those? And I think that skill is, when you have a fever, people will sort of know what to look for. But in wound care, we haven't developed that sense, that skill. So I think that's one of the main problems. And then what can happen to a wound? Because the other thing is that we consider the wound as the problem, but the wound is only the problem surfacing. So if you can't figure out the underlying problem, you're stuck as well.
And I guess that's where all the new biomarkers and bacterial fluorescence imaging and all these adjuncts are coming in, which perhaps we wouldn't have had 10 or 20 years ago when we're trying to diagnose wounds. And I suppose we now have this spectrum of bedside tests, other adjuncts, other investigations that maybe they wouldn't have had many decades ago when they were treating wounds. We've got the luxury of the technology evolving perhaps at a faster pace than we can keep up with in some instances.
Well, yes, because to yield a biomarker product or biomarker medical device, you need the knowledge to figure out what you're looking at. And the other problem is that we actually don't know. There's only few people in this world who are able to translate, for instance, an increase in interleukin to relate that to a process happening in the body. So I think we're not there yet. And I remember that's just already 3 years ago, we tried to set up a large biomarker fishing expedition here in the Netherlands. And during that process, I realized we lacked the knowledge to ask the proper questions. And that's a fundamental one.
Interesting. And in terms of other big myths and misconceptions, I know me and you have had this discussion before about why is it so hard to get good clinical evidence or good data in wounds in terms of, doing... I mean, this is something we've discussed at length before, but do you think that's another myth and misconception, is that actually...
No, I think it's that is like a wound is a problem surfacing, not having proper Cochrane reviews or proper evidence is also a surfacing of a problem. And before, and there are lots of people who are complaining about, oh, we have no double-blind studies, we have no meta-analysis, we have no data, we have no proper research. And then they start complaining about the research and the lack of it. But I would first start with asking the question, why don't we have that? And that is a far more interesting question. So why don't we have that? Why is Cochrane coming up with invariant or small variations of we need more evidence, we don't know it? Why is that? And I think one of the main reasons is that and then we're back to the fever parallel. You can have a fever for many reasons. So can you have a wound for many reasons. And what the wound is doing depends on the underlying problem or problems, and there can be several of them. And that means that if you have a wound which is caused by something underlying, like the easiest one, of course, is a vessel closing or something not happening properly. If you have a wound with a vessel underlying, whatever you do to the wound will not respond or only respond minimally, but you will look at the variation of what's happening to the vessel. So if you have 10 patients with varying arterial problems who have varying diffusion, and these diffusions remain the same or progress over time, I can tell you that what you will find is in your data is the progression of the underlying disease and not whatever you put on the wound. And as long as we don't correlate for those types of problems, we're not going to see any evidence. So I think the lack of evidence is actually a proof of the lack of fundamental understanding of what we're looking at.
Harm, interesting. Why do you think we have so many dressings on the market? In terms of why is there this constant evolution of trying to get a better product for debridement, a better product in terms of alginates, in terms of non-adherent dressings, or why do you think there's this constant cycle of new products?
Well, that is the easy part, actually, because as you have a wound, the problem in wounds is not as much as logistics of the patient as logistics of the expertise. And I think it's 400 years ago we decided that neither the doctor nor the surgeon will take care of wounds, so we placed it in the hands of the nurse. And the nurse has very limited resources to heal a wound, so they turn to dressings. That means that, and that's what we started with, it's this nurse doing this leg ulcer with only dressings. That means that nurses are currently totally focused on what dressings will do. And then the companies will support them in that by supplying more dressings. I vividly remember talking to a couple of nurses in the Netherlands who just finished their educational project. And I was having a bunch of products for them. I filled up a basket with nice products, but all those products have one thing in common, is that you could turn on the knobs in the wound. You could increase or decrease inflammation. You could reduce the production or take away overfluous matrix metalloproteinases, stuff like that. And within 5 minutes, I noticed these nurses thinking, ooh, how do I get rid of this man? Because I don't know what he's talking about, but it is certainly not my field of expertise. So if you do anything different but applying a dressing, which comes down to, very bluntly, a artificial blister with one or two adding substances, like something which kills bacteria, they will not listen to you and they will not buy your product. So all the innovations we see are further extensions of the current product base. And that is, and one thing we know is that that's what you learn from Cochrane. There's no evidence going to come from that, because there's a misunderstanding of what's happening, what really a wound is. So that's the hard part.
Interesting. And do you think, in terms of the context of trials for wound care data, do you think that it's hard to get controlled? So get an identical wound as a control study? Is that part of the challenge? Is it the study designs? Why is it that we struggle in wound care to get the same trials that they would have, for instance, in a different subspecialty?
Well, the main problem is actually return on investment. If you have a pharmaceutical product which is promising, you know you will get a return on investment of several billions euros or dollars or whatever. If you have a wound care product, you will not have that. So to overcome, for instance, if you want to overcome difference in perfusion in several patients, you don't need a trial of 10 patients or 20 patients. You need a trial of thousands of patients. And then statistics will iron away all your problems and hurdles. Because that's the numbers, but the market is not sufficient to support that. And since doctors consider wound care not interesting, and doctors are in charge of paying for fundamental research, also the fundamental research is not interested in doing that. So on both sides, from the industry and from the governmental organizations, there will be no interest in sufficient funds for doing real good trials with sufficient patients. So that is the first problem. And the only way around that is to find other secondary endpoints to figure out what's going on in the wound, or be able to translate whatever you find in patient A to patient B.
And that's all very interesting, Harm. But there are lots of myths in wound care, aren't there? What would you say are the sort of top 5 myths that exist in wound care these days?
Well, the first one is that dressings heal wounds. I would say that is it's not untrue, of course, but if they did, we would have the evidence for that, and we don't. So that's the first myth. The second myth is that doctors think they're very good at healing wounds, which can be true, but normally they're not good at healing wounds. They're good at healing underlying problems, as a result of which the wound will heal. So that's the second myth. The third myth would be, I'm quite sure about that, is that you don't have to listen to nurses because they are not able to handle problems in a real manner. That is rather devastating for the outcomes of wound care results. So the role of the nurse is because everybody talks about, we need multifunctional teams, but then if you have a wide range team, a lot of expertise in it, you actually have to listen to each other, which is hard for medics in between themselves. But from a doctor to a nurse, that's even harder. So that would be misconception. Another one. And then the final one is that, the final one is that people think that a wound is a wound and that it is a hole in a patient. And I would say that that's not the case. It is an example of tissue damage which has reached the surface. So if you look at wounds, you shouldn't think about the wound itself. You should think about tissue damage. And then you get all kinds of funny parallels, because then if you go into medicine, you are able to connect to other fields. Because there's another place where they have tissue damage where they can't reach it, and that's called cardiology. There's all kinds of funny research. Cardiologists do fundamental research, which are directly applicable for wound care. One of them.
Yes, in terms of sort of, I saw that you recently discussed in terms of adding cell therapy to the reconstructive ladder, and that we shouldn't always be thinking of surgery is not always limited to the macro. We should also be looking at the micro scale. So I guess as a wound biologist, you're very interested in that micro level of intervention that can improve wound healing.
Yes, well, I think there's a saying from Goethe already. He said a few hundred years ago. He says, if you can't find the interrelated aspects of what you're looking at, if you can't find the links between them, you're not looking good enough. So I'm quite sure that whatever is happening in let's take a simple wound, but you will notice that there are cells doing stuff within cells. There are things happening. There's chemicals. There's redox reactions happening in the cell. And then the cells are in tissue, and tissues together form complexer tissues. And then you have organ systems, and that works together at the body parts, and then the body parts in your body, and your body is part of a society, and society is part of a larger society. So when I teach people, I tell them whatever happens in this wound right now depends on factors in angstrom sizes up to to thousands of kilometers. That's the first step. And the other thing is that it also goes back from 1 millisecond before to 3 billion years before, because there are some aspects in wounds which we already have learned like 2 billion years ago, and we're still doing that. Which is that, I mean, if you look at the calcium pulse, for instance, which is one of the first signs of wounding, that is so old that has started already before the plants and the animals separated. So that's a joint signal we have for both of them. Well, that's what you get when you talk to biologists about wound care. It doesn't necessarily get easier, but you see more the connections between them. Before you know what to do with a wound, you have to really understand what's going on. So then they have to go back into the evolutionary aspects of wounds, because that tells you, for instance, the whole centerpiece of wound care is energy balance. The reason you have a scar is because it will suffice to protect you. So whatever the energy spent onto making it perfect is better spent on making offspring, because the whole idea is that nature is about turning energy into offspring. That's the game. That's the fundamental game. Yeah. And then from there it starts. And then the first wound is like, I always say, you're sitting on a rock in the sea and you're trying to get food in, right? And then suddenly you see your neighbor next to you is doing the same stuff. So you think, well, I have to one hand on the rock and one hand to grab food. Well, what if I hold you with my two hands? So you can use two hands to catch bigger prey. So together we're better off, right? That's from singular cell to multicellular aspect. That took us 2 billion years to develop that idea in nature. So the moment, and then it gets funny, because if I die, I can't make any offspring, right? So the moment I have my neighbor in my arms and the seas get rough, I sort of can start thinking, well, I've got rid of him. I've got my first wound, right? But if I don't get rid of him, yeah, I might kill myself. Sorry, neighbor, you have to go. So that's the new thing in wound care, because normal cells die by themselves, yeah. But if you are in a multicellular environment, you suddenly get altruism. So you get cells, you can kill other cells just for the better benefit of the organism. So there you see, even in cell damage already, you see that simple decision of holding hands with your neighbor introduces a whole new category of damage forms. And that's the starting point. If you look at the data, you see that if people get older, I have now a few thousand patients I can fiddle around with. So I can look at the data there. So then and you see, if you plot them all in one graph, you can plot them from 0 to 100 years old, and you see a gradual increase or gradual reduction of wound healing speed. So you see it. So then I thought, okay, that's nice. But could it be that these old people have different types of wounds compared to the small ones? So let's look because I have also a group of people who have been bitten by their dog or their cat. So let's see how this ingression still works there. And there it turns out it isn't there anymore. So and it tells me that if you're healthy, your wound healing speeds don't deteriorate that much if you're getting older, as we all think. It is only, and then you get the wound healing speed per se is not going slower, but the chances that your wound healing speed is going slower increases, which means if you look at large numbers of data, you have the impression that it gets worse. But it's not the case. It's only that the chance you have something else which is causing it.
Absolutely. And certainly when you look in the surgical setting, when you operate on a very young baby and you operate on a very, very elderly patient, those two groups actually heal much quicker. And obviously it was attributed to the collagen ratio in the skin, fetal skin, whereas the elderly age group. But certainly that would fit your hypothesis.
Yeah. Yeah. So it's, and the only thing I continuously do is asking myself the question, is that so? And why is that so? And that's the only thing I can do to drive progress.
It's been a real pleasure. Thank you again for joining me for the first Wound Masterclass podcast.
Oh, that was great. A great conversation for our first podcast.
Yeah, it was really enjoyable spending that time speaking to Harm. And we're excited about, the future ones that we have coming up, aren't we, Alec? The few coming up next week.
Yes, we certainly are.
And the ones coming up are going to be on innovation, how to introduce innovation into your clinical practice. That's the next one. So please stay tuned. Please give us some feedback on how you thought this podcast went. And we're really excited to have so many of you tuning in to our events. So thanks again, and we'll see you next time.